Thank you for having me here today. I'm very delighted to be here and to talk a little bit about program science in the context of the work that we do within community organizations. I think James gave us a really good example of large-scale interventions, and hopefully what I'm going to be able to show today are a few examples of how program science, or at least pieces of program science, have been integrated into the work of some of the work that we're doing at ACT. So really what this means for us as service providers. So a little bit of an overview of what I'm going to talk about today. I'm going to sort of give my take on program science, and what it means both for program managers and for those that are actually implementing programs and services. And I'm going to highlight three interventions situated at ACT. One called GPS, Gay Pause Sex. The other called Towel Talk, which is a bathhouse counseling program, and a new project that's actually just beginning, which is called the Serodiscordant Couples Group. So I'm going to give a little bit of background on program science and really just say that while implementation science is primarily concerned with the proper implementation of evidence-based interventions, program science is concerned with what I'd say three additional aspects of programs. And first of all, it's the strategic focus and timing of interventions. So who are we targeting? Really knowing who we're targeting. When are we going to be doing this intervention? And for how long? Secondly, the optimization of the mix of interventions so as to achieve synergies and to avoid antagonisms across interventions. So recognizing that, I think as we all know, there is no one magic bullet, whether it's about an HIV prevention program or a support program, that there need to be a mix of interventions, and really being conscious of how those interventions can work together and actually not be working at cross purposes. And the third area is really program management and the whole and implementation processes that are necessary for optimizing intervention coverage and quality. So the focus of program science extends sort of beyond the implementation and coverage or the scale up of an intervention, and really focuses on the development of the program in its whole, including issues of resource allocation, the definition and prioritization of the target population or target populations, developing and prioritizing interventions and packages of interventions, identifying stopping rules. And I think that's something that those of us who work in community organizations are reluctant to do. So we roll out a program, and we've been doing it for years, but we never actually think about when it may no longer be useful. And obviously, issues such as advocacy and community mobilization. So program science, for me, integrates different spheres of practice, including strategic planning, policy development, program implementation, program management, monitoring, and evaluation. So practically, for those of us working in the community, what does this mean? I would say we need to know our HIV epidemics, and we need to know as organizations who we are serving or who we want to serve. We also need to understand HIV transmission dynamics, and also, for those of us who are developing and implementing support programs, understanding the needs of those we serve who are living with HIV. And based on that, making sure that resources, often money, follows the epidemic, that the interventions follow evidence, and that the information improves the efficiency of the implementation. So each HIV service within an HIV program is implemented using a streamlined process, and where feasible and where it makes sense, HIV services are integrated and linked, with referrals happening within organizations, outside of organizations, and I would argue increasingly outside of the HIV sector. So that sounds good in theory. But what does it mean practically for those of us who are implementing prevention, care, and support programs? For me, program science isn't only something done within the context of formal research studies, But it has implications for program implementers, so for frontline staff doing the work, and for those that are helping to monitor and evaluate programs, and that could be program managers within organizations. Program science has the benefit of ensuring that our programs and services are responsive to the changing needs of the communities we serve, and it acknowledges that in order to be effective, whether in terms of reducing HIV transmission or improving the health and well-being of people living with HIV, that there is no one intervention that's going to work, and rather interventions need to be clearly targeted, be offered in tandem with other interventions, be regularly monitored and evaluated, keeping in mind that we don't want to place so much emphasis on monitoring and evaluation that we can't actually do the programs that we want to do. But we want to make sure that they continue to meet both the individual and community needs. And as needs change, those programs be modified and perhaps, dare I say it, be stopped. Those of us who've been working in HIV prevention programming have known this for years, that to be effective, prevention programs must be targeted, so you must know who you are trying to reach, and that prevention requires many simultaneous interventions in order to be effective. So information provision to increase knowledge about the ways that HIV is and isn't transmitted, to making sure that that information gets to the community members that we're trying to reach, that messages are disseminated in many different ways to those communities, be it in person, be it online, be it in print, that the tools to reduce HIV transmission are made available, condoms, lube, harm reduction supplies, and they not only be made available, but they may be made accessible within the community. And obviously for this to happen, it needs to happen in tandem with community mobilization strategies. There also need to be interventions to raise awareness of HIV and STI testing and treatment, stigma reduction programs, both stigma against those living with HIV, but also the communities most affected by HIV. And an understanding that issues related to racism, sexism, homophobia, heterosexism, transphobia, negative views about sex, sexuality, and substance use all impact on HIV transmission and therefore must be addressed in our programming. And so increasingly, HIV prevention programming must also address the social determinants of health and how these issues such as income security, gender, culture, factors such as social inclusion or exclusion increase vulnerability to HIV. And this makes our work much more complex and requires coordination both within our organizations, within the HIV sector, and beyond the HIV sector. And it, of course, requires us always to be monitoring and evaluating the effectiveness of our interventions, scaling up, scaling down, changing as needed. And the same holds true for support and care programs. Again, it's important to know who we're trying to reach, know your epidemic. That support and care programs also require many simultaneous interventions to be effective, information on how to increase knowledge about managing living with HIV, interventions that reduce social isolation, build skill, capacity, and resilience, programs that engage people living with HIV to increase control over their health and well-being, skills building that enables people living with HIV to achieve their own self-identified goals. And of course, care and support programs for PHAs must address the social determinants of health, as I outlined before. And so the work is much more complex and complicated than it ever was before, and therefore it requires coordination, both within our organizations, within the HIV sector, and beyond the HIV sector. So keeping in mind that program science requires us to think about the following, so the strategic focus and timing of interventions, who to target, when, for how long, the optimal mix of interventions so as to achieve synergies and avoid antagonism, program management and implementation processes that are necessary. What does this all mean for program managers and implementers? So to the first point, about focus and timing, again, this means really knowing your epidemic, knowing who you want to serve, who you're currently serving, knowing if others are already serving these communities, knowing what is happening already out there and when it is happening, and also knowing through evaluation whether a particular intervention is no longer achieving the intended outcomes. When we talk about optimizing the mix of interventions, this requires us to be closely working with partners, both, again, within our organizations, within the HIV sector, and increasingly outside of the HIV sector, given the complexities of issues facing people living with and at risk for HIV. And by doing this, it helps us, when we're working with researchers and evaluators, to optimize the global mix of interventions and then develop novel interventions where gaps have been identified. And this can sometimes be seen as a challenge, especially when we're working with limited resources and in cases where we've been doing a particular intervention for years. There often is a fear within organizations of stopping a program or an intervention, as that'll be seen as taking something away from the community. But instead, I'd argue, through monitoring or evaluation, one can determine whether or not that intervention is actually having the intended impact and the outcomes. After all, needs change, and programs and services need to change. And by monitoring the impact and outcomes, we can modify or, dare as I said it before, stop programs if they're not achieving what we intended them to do. By being mindful of other programming inside and outside of the HIV sector, we might actually determine that a program that we're offering could be better offered somewhere else with better results. And in that case, we can collaborate with others to determine if our service users could be better served by moving a program somewhere else, by collaborating with somebody else, and determining whether or not that other organization may in fact be better placed to serve that population and may in fact have the resources to better scale up that intervention. So given that program science is concerned with a mix of interventions, doesn't this then mean that we as individual organizations must be offering a whole range and mix of programs within our organizations? And doesn't that mean then that we're duplicating services? I would say not necessarily. By knowing what others are doing within the sector and outside of the sector, and providing greater referrals and linkages between programs in organizations, programs within other AIDS service organizations, and programs outside of the HIV sector, we can ensure that those that we're serving have access to a wide mix of both HIV prevention, care, and support programming. And to the third bullet, program management and implementation processes. Often, this is an area in which we fall short. We develop an intervention based on a need after having done some research to determine a service gap, and we implement a program. But we don't do enough to actually monitor the program or evaluate its effectiveness. Needs change, community needs change, and through program management and evaluation, we're able to know about these changes. We're able to know more about how the program can be modified to better meet those changes. And we can also know how the program may need to be scaled up or scaled down. And in some cases, we can use this evidence to make the case and advocate for additional resources to scale up an effective intervention, to change an intervention, or to stop an intervention and to try something new. So that's sort of my take on program science and how it relates to those of us working in community organizations. And now I'd like to provide you with 3 examples of interventions that utilize aspects of program science. While some of these are part of formal research studies, others are not, and I think that's the key. So I hope that they help to illustrate different ways in which program science can have practical applications for those of us working within community organizations. So the first example is GPS, Gay Pause Sex, and the website is there and you can definitely find out more about it. So GPS began in Toronto actually over 5 years ago following a request from Ontario's Pause Prevention Working Group, which is part of the Provincial Gay Men's Sexual Health Alliance. Over time, this intervention has been changed and tailored based on feedback, not only from participants, but from the experience of the facilitators who were actually delivering the intervention, and from the ongoing research that is part of this project. The overall goal of the intervention is to reduce HIV transmission among HIV-positive gay men through a pause prevention intervention that targets HIV-positive men who have unprotected anal sex with men of unknown or of different HIV status. However, given the stigma associated with barebacking and fears associated with the increasing criminalization of HIV non-disclosure, the intervention as it initially started has changed and evolved, both in terms of how it's promoted within the community and also the ways in which it's delivered. In Toronto, it's housed at ACT, but it's part of a research component conducted through the HIV Prevention Lab at Ryerson University. And more recently, within the past year, the intervention's actually now been transferred over into Vancouver, where it's housed at Positive Living BC. And there, the research component is being facilitated through Simon Fraser University in collaboration with the HIV Prevention Lab at Ryerson. The research components of the project include questionnaires that participants complete before the program begins, and 3 more questionnaires over a 6-month follow-up period upon completion of the program. Each questionnaire asks similar questions about participant demographics, about mood, about personality, about preferences, and about sexual behaviors in the past 2 months. And participants are then asked to do an in-depth interview with a research coordinator following completion of the program. The research has provided us over the years with evidence that actually supports this kind of sexual health programming for gay and bisexual men who are living with HIV. One that's asset-based, one that affirms gay men's lives, one that affirms gay men living with HIV, and one that affirms sex and sexuality. And I want to just pull a quote actually from the GPS website and read that for you. The program helps participants discover the best things about their sex life, figure out how to get more of the sex they want, and determine how to minimize or even eliminate some of the things they want to change. We believe that each participant may have his own goals for having hotter and better sex, and we're here to help each guy achieve his goals. Overall, the purpose of GPS is to build men's confidence in themselves when it comes to making the changes that they want to see in their lives and getting the best sex that leaves them feeling satisfied and empowered. And at the heart of the GPS program is the peer-facilitated process of clarifying and working towards a sexual health goal that the individuals in the program identify for themselves. And a foundational belief is that sexual health includes having great sex. And it's not just about talking about sex. It's actually about getting men to help, getting men that are involved in the program to actually have the kinds of sex that they want. And a recognition that a healthier sex life connects deeply with other parts of people's daily lives, like their social, mental, and physical stresses. This intervention has been specifically targeted to a specific subgroup of HIV-positive gay men. And that was based on prior research that actually identified, and this was research done by Barry Adam, of subcultures of gay men, particularly HIV-positive gay men who were not having safer sex. It's part of a formal research study. And participants are not only followed up to see if the intervention has had a positive outcome on their overall sexual health, but the intervention itself has actually changed and adapted based on the feedback from men that have been in the program. The program itself has now expanded so much that we're actually doing another pilot in Vancouver, as I mentioned earlier. It's a peer-based project run by and for gay men living with HIV. It's informed by a working group made up of predominantly HIV-positive gay men. And as I said, the curriculum has shifted and changed based on feedback from participants while remaining true to its intent, which is to improve the sexual health of HIV-positive gay men and thereby reducing HIV transmission. Different example, Towel Talk, which is a bathhouse counseling program housed at the AIDS Committee of Toronto. It's funded by the Ministry of Health and Long-Term Care AIDS Bureau, and the project started as a collaborative effort of a number of AIDS service and other organizations in Toronto involved in prevention and health promotion activities. Towel Talk was meant to augment the existing sexual health promotion services that are being provided by a variety of AIDS service organizations in Toronto who go out into bathhouses, speak with men, provide condoms and lube, make referrals. But the program actually places professionally trained counselors in bathhouses. And the counselors offer bathhouse patrons anonymous and brief counseling sessions that can last anywhere between 10 and 45 minutes, as well as referrals to other community and health and social services. The counseling takes place in a private room in a bathhouse, which may seem like an odd idea for anyone who's actually been in a bathhouse. And the counselors are also able to provide short-term follow-up counseling, up to 8 sessions outside of the bathhouse. And they can also provide streamlined counseling referrals and referrals to other community services. Placing a professional counselor in a male bathhouse is really one response to current research findings that show us that there are complex psychosocial issues and that can shape gay, bisexual, and other MSMs' vulnerability to HIV. So a counselor in a bathhouse is able to work with these complex psychosocial issues that shape gay and bi men's experiences, as well as address situational issues, so things that may come up in the moment within these quick sex environments. The project also came out of a realization that research evidence has actually shown that brief counseling can be effective in reducing risk behaviors. So where did the project come from? It actually came from a presentation that happened at a Gay Men's Sexual Health Summit in 2007. This is a presentation by a health promoter at a bathhouse that was just about to come into Toronto called Steamworks, an American bathhouse. They had a program there called Mr. Sex, and this individual was a health promoter who actually provided counseling services within 2 of their Steamworks locations in Chicago and in Berkeley, California. A lot of us who heard the presentation about it were very intrigued about how this might work. And then shortly after, with consultation with the Ministry of Health, a program advisory committee was struck. And we started to look at whether this might be something we could try to implement in Toronto. And although the Mr. Sex project had been active for many years in the U.S., it had actually never been evaluated to see whether or not it was effective as an HIV prevention program, nor had it ever been evaluated to see whether placing somebody in a bathhouse actually had an impact on the experience of men who were going to a bathhouse, clearly for other reasons. It's important to note that Towel Talk it's not the implementation of Mr. Sex in Toronto bathhouses. It did draw a lot from the experiences of that project, but it was actually developed within the specific context of Toronto, drawing on the expertise of those who were brought together on the advisory committee. The evaluation of Towel Talk followed formative and process evaluation structures, seeking to gather relevant information in order to inform the program development, as well as identify key elements of the program structure. So we had a number of questions which focused on the feasibility of implementing a mental health intervention in a sexualized environment. And in the evaluation report, and it is available on the ACT website, if you go to the Towel Talk page, there is a link there to the full evaluation report, which was completed in 2011. We tried to answer the following questions. So how do outreach programs, so the work that others are already doing, either through staff or volunteers, providing condoms and lube, making referrals fit within the bathhouse environment. Oh my God, 5 minutes. Is there support from the bathhouse community? So from outreach workers and staff, from volunteers, from the bathhouse patrons, from the bathhouse staff itself for a service like this? Will this counseling intervention augment what's already being provided, or will it be seen as a duplication of services? And this is important. Will men actually access a professional counseling service in the bathhouse? We also wanted to find out, will counseling sessions feel safe and private? And will the program be able to link men to other services? So does it actually lead to referrals to other services within the community? And in what ways would this program have an impact, either negative or neutral or positive, on the bathhouse environment? And then finally, how could we actually improve the services? One of the things that we found was that Towel Talk enabled men who would not otherwise access counseling in traditional settings to get that service. In other words, we're going to where men were rather than expecting them to come to us, thereby increasing access. The evaluation component was developed within the program's design. So it wasn't something that we did afterwards. It was done throughout the whole process. And that included a needs assessment of men in the bathhouse. We actually surveyed 115 men. We did focus groups and interviews with bathhouse managers, outreach workers, and volunteers. And then we did follow-up interviews and focus groups with bathhouse managers and outreach workers a year after to find out, okay, the program's been in place for a year now. What do you think about this? We also got feedback forms from men who had actually accessed the program. And each year, information about the nature of the topics that are discussed in counseling, the demographics of the men who are accessing the services are analyzed. And this has actually helped us to shape and change the program, to identify where we need to be and when we need to be. It's also useful because those common emerging themes are then shared with others in the sector and have helped to identify gaps and linkages that we've been able to make with other mental health and substance use service providers have allowed counselors to increase access to these services. And you can see from the following slide, it's really difficult to see, I apologize, but you can see that there's this past year was the 5th year of the program, and that's a blue line. And then the other line is all the other years before. You can see the range of topics that get brought up by men in counseling. Anxiety and stress being number one. Issues related to being bisexual. Coming out issues, risk reduction, sexuality, race and ethnicity, aging, employment issues, stigma, substance use, immigration and settlement issues, and obviously HIV transmission. So you can see that there are a lot of issues that are coming up from men within the bathhouse setting. So, as I said, Towel Talk has been guided by an advisory committee. The advisory committee is actually one of the subgroups of the committee has actually been working to manualize the intervention. So really to develop guidelines for the program so it can be used elsewhere. And we've already gotten interest from both Montreal and Winnipeg to try to implement the program there. And we're hoping when the guidelines are actually finished later this year that we'll actually have something that others can take and adapt as needed within their own communities. As I mentioned, the program has adapted and changed over the years based on the needs that have been identified by the men. And I think one of the things that's really come out, and I think it identifies for us a structural issue, is that there are some of the challenges that many gay and bisexual men have accessing culturally competent mental health and substance use services in our city today. So this has implications for policymakers, funders, and allied services. I know I'm going over time, but I want to quickly talk about a new project, which is a serodiscordant couple support group. It's a collaboration between the Clinic for HIV-Related Concerns at Mount Sinai, ACT, David Kelly Services of Family Service Toronto, and the Center for Spanish-Speaking People's AIDS Program. It's funded by the OHTN, and the project is actually going to help us to develop, implement, and evaluate a participatory psychoeducational support group for pos-neg couples here in Toronto. And it actually came out of conversations through the HIV and Mental Health Network here in Toronto, which brings together service providers, mental health service providers who work in the HIV field, who had really identified this gap, that there was very little in the community for folks who were in relationships where one partner was HIV positive and the other was negative. We also did a needs assessment at ACT in 2010, and again indicated that there was a real need for something for serodiscordant couples. And so given this gap in group-based support services designed to meet the needs of those in serodiscordant relationships, this research proposal was put in to engage serodiscordant couples, and I think that's the key point. In a participatory project. And the objectives are really as follows: to improve our understanding of the support service needs of serodiscordant couples, to develop, implement, and evaluate a support group using a collaborative participatory approach, to develop knowledge and assess the impact of using a participatory approach in program development, implementation, and evaluation, to increase the capacity of current and future frontline service providers and people living with HIV or affected by HIV to engage in participatory evaluation processes. And that includes piloting an innovative community-informed group program. And to generate a set of recommendations regarding the implementation of the programming for serodiscordant couples. It is, by nature, a participatory research study. It includes formative process and outcome evaluations. The evaluation components have included an environmental scan of programming for serodiscordant couples, an online needs assessment survey, which has been completed, the development of pre- and post-group evaluation forms, a review of program-related documents throughout the project. And I think what's really key is the actual involvement of members in this pilot group. They're actually helping to shape the content of the group. They're actually going to be involved themselves, working with the research team and with the facilitators to actually evaluate the process of the group itself, the process of the project itself. And I think what's really important is generating a set of recommendations regarding implementation of group programming that can be used in terms of working with serodiscordant couples. So those are three examples that I've given that I think sort of touch on the integration of programs and sciences. And I want to thank you all very much. And here are a couple of questions that I have for you that we can talk about. So hopefully we can put up both slides and we can get people talking. Thank you very much.